with them. I have no conflicts of interest. And I think that the first three questions we must ask ourselves in patients with devices is whether it is possible to get quality images, whether it's sure and or safe, and whether I can do it at my institution. We are going to answer these questions one by one, but in general, the first thing I would like to do is to ask you, how many of you in your institutions are doing MRI in patients with devices? 4 hands up. Well, we have the idea that most people are not doing it. And the answer to these questions is that it is possible, it is safe, and the answer of whether I can do it in my institution or not, well, that depends, because not every institution is prepared or have the necessary infrastructure to do it. This is an interesting study I found after Luis asked me to give this talk. And it's a survey they did in Italy with 32 questions among a long list of cardiologists, approximately 200 cardiologists. Only 70 responded. How much do cardiologists know about cardiac resonance and their use in patients with devices? And this was very interesting because despite the fact that MRI has been used for over 15 years, and you electrophysiologists use it a lot, for the general population of cardiologists, it is still a remote technique. It's like the dark ages of doctors that make very peculiar images that give at the end a report. And here we try to go over the difficult cases and try to become like your GPS for ablation of everything you do in cardiology labs. And this is the list of some of the questions asked to those Italian cardiologists. Whether coronary stents were compatible with the magnet, are external wires compatible, and mechanical valves, what is a conditional device? How safe? What is a safe time frame between the device implant and a scan, and when are checkups necessary? And what are the risks of the device? Later on, we will see the answers, but the idea is that we become familiar with the terms and the answers to these questions very quickly. Most of them thought that no prosthetic valves or any patient with a prosthetic valve may be placed under the magnet as long as the gradients are normal and the device was placed after more than 3 months. Half of the cardiologists thought that no images could be made in coronary patients. I was trained in Boston, and we have a protocol where patients with stents, with STEMIs came, and we did the MRI 2 days later. And many did not believe that these low recorders could be compatible with that technology, but this is not true. We know that most of loop recorders are compatible. So we have to respect the magnet, of course, and this is the most important point. There are differences in size and in the strength, the power in terms of the gravitational capacity. In terms of size, definitely magnets are smaller than planet Earth. However, a device or a magnet of 1.5 Tesla has 30,000 times the gravitational power of the planet. So it's not to be underestimated. It's 30,000 times more potent than the planet, and 0.3 Tesla are 60,000 times more potent in terms of gravitational force. So if you respect the magnet, you realize that changes in the orientation of protons that occur in the body when we enter the magnet are very important. Another thing to keep in mind, those of you that raise your hands when I ask you whether you were doing MRIs in patients with devices, is that the magnet is on all the time. Even if there is nobody in the room, the magnet is on. The magnet is never turned off. If it turns off, it's because there is a major damage. But the magnet is active all the time, and that's why accidents occur. Here we see a chair we see a vacuum cleaner and an oxygen canister. And deaths have been reported, patients who die inside the magnets because somebody who is not familiar with the MRI environment makes a mistake. For instance, a canister that may result in a head and neck trauma in a patient. So this is the first thing with regards to MRI and devices. Precaution, warnings, mobile phones, keys, pagers, well, all of them can be damaged. And medical equipment such as ventilators, as you saw, monitoring equipment, infusion pumps, oxygen cylinders, and hydrocephalus shunts may also be affected under the magnet. Another important consideration is that in addition to respecting the gravitational force in 1.5 and 3 Tesla is the quality of the image. These are cases that you will see tomorrow. The two-chamber view and the two-chamber view. This is just a highly abnormal MRI. This is an interesting case we will see tomorrow, and this is a case we did with our magnet here, 1.5 Tesla with an excellent image quality. And these two are very similar to what happens with the 1.5 and the patients of MRI in devices. They are compatible. We like to do MRI in these patients with 1.5 Tesla. These two are not compatible or are less compatible. There are some articles, and when you review the literature, you will realize that there are 12 researchers that placed the patients under the magnet below 3.6 Tesla, but most of the sections that have been used use 3.0. And the reason is basically twofold. One is 30,000 times less potent in terms of gravitational force, and second, they offer less artifacts for the interpretation of the test. And very important, when you buy a magnet, an MRI, usually the cost is between $1.5 and $2 million. If you are considering buying a magnetic resonance machine, it's a very expensive technology. That decision has to be made with the radiologist, particularly the neuroradiologists and the skeletal muscle radiologists. They love it. They are fascinated because of the quality of imaging for their studies. But if you decide to buy a 3.0 Tesla, you can be assured that your institution, there is 1.5 if you are planning to start a program of cardiovascular images where there is the potential of treating patients with devices. Otherwise, it would be much more difficult and the challenges will be greater. I was talking about the 60,000 in 3.0 Tesla, and as I mentioned before, stents. Wires and any valve are not contraindications for the device. One of my professors in Boston didn't like to do the cage birds, the valve inside the box, I don't know. Well, he didn't like to do it, but with time you learn and you realize that even those patients can be done safely as long as the implant was done at least 3 months before. Regarding other contraindications, there are two documents, one from 2010 and another one which has not yet been published where there are more updates. It is published by INDI, the consensus of the HIS, which is still in the press. It has not been published, but it's a document, but I think that you have to read conscientiously. It's 20 pages with a little bit of physics, but it's important for you to read them. Which are the contraindications? CNS clips, ocular foreign body that may move or cause blindness or an important trauma, bullets in critical areas, in certain areas of the abdomen, near vessels, for instance, patients with swan guns. Devices used to be a contraindication as well as pacing wires, but this has been reevaluated. Cochlear implants continue to be a contraindication, neurostimulators, and hydrocephalus shunts. With regards to the terminology, it's MRI safe. When we say it's MRI safe, there is a green light when it's made up of materials that are considered to be safe with no danger whatsoever. This includes non-conducting materials and non-magnetic materials that cannot be attracted by the gravitational force of the magnet. Now, MRI conditional meaning, it's any item is safe for use under MRI machine only under certain conditions. And those particular conditions for devices and for pacemakers is that they should have a low carbomagnetic components. St. Jude and all these companies have focused on reducing the load of ferromagnetic or iron magnetic components to have less attraction by the magnet. There is no known danger, and both the generator as well as the electrodes should have the same characterization. If I replace the electrodes with a conditional, but the box is not conditional, that turns the system non-conditional, and that completely changes the way we approach those patients. Generators and electrodes must be conditional. And the interval time is 6 weeks. After 6 weeks, we consider that the system is stable to be able to scan the patient. Most sites wait up to 12 weeks unless it's an emergency, but 6 weeks or more than 6 weeks is the safe time. And what is unsafe? Well, aneurysm clips, insulin pumps, oxygen tanks, FM Caesars. So they are safe, conditional, and unsafe. And I think it's fundamental to learn about the risks when you're placing a patient under the magnet with devices, because this may become a very dangerous situation. Or this could be a procedure that usually doesn't have any complications. So knowing the risk is absolutely indispensable for this type of procedure. So let's go step by step. There are six known risks. Let us see how we can mitigate them. One is the mechanical movement of the electrode or the dislocation of one lead. And it depends on whether it's 1.5 or 3 Tesla. The paramagnetic component is very important, and it's proportional to the distance between the MRI and the device and the time from implant. If you start playing with the magnet, you start doing scans in patients after 2 or 3 weeks, probably the stability is not the same and there can be movement. Rare, particular with 1.5 Tesla, and can be prevented by using conditional devices and avoiding the 3 Tesla magnets. What else can happen? Well, there can be current induction and warming or heating of the tissue, which causes interference of the electrode at the level of the lead interface. This results in radiofrequency pulses and induce current, tissue heating, necrosis, change impedance, reduce sensing, and elevate threshold immediately and long term. And there have also been changes reported in the battery. It is more frequent in epicardial devices and abandoned leads, and that depends on SAR. You have nothing to do with SAR. We do. What is the SAR? The SAR is the specific accession rate, and it is the radiofrequency power absorbed per unit of mass of tissue, watts per kilogram. This is a complex variable that depends on many things, and it is calculated by software from the average forward power passing into the RF coil and the body mass at the site where the radio frequency is being transmitted. Real weight is crucial. Both men and women lie about our body weight. Usually we take off 5 to 7 kilos, and this can be important when we are scanning patients. We have to weigh patients and calculate an exactly and accurate specific absorption rate. This is the difference of 1 Tesla increases the SAR considerably. So you minimize SAR. This is something we do. We work with our physicists. And another thing we can do to reduce the risk of warming and current induction is to try to avoid doing studies in patients with epicardial and abandoned leads, and to judiciously check the device before and after the MRI. This is the group with whom we are working from Michigan. Fran Bagula is the director of the cardiac resonance program. And these are our partners to start our devices program. I believe that they are very courageous because of their experience. They have been shown, like in this cohort of patients, that they have scanned patients with abandoned leads as well as with epicardial leads. This is the spectrum of experts. This is just to show you that this is possible to do, but after having a long experience, a lot of experience before you start doing this. And there are some differences in the battery, in the atrial impedance, and in the impedance of ventricular electrodes, which are statistically significant, though probably you will correct me if I am mistaken, but probably clinically there isn't much difference. This is what they found in 142 patients immediately after the scan, 1 week later and 3 weeks later. So what we do under the magnet impacts the patients less in these leads which are not epicardial and which are not abandoned, but they do happen. How do we minimize this? Well, by reducing SAR, as I said before, and by avoiding that type of patients. What may happen as well? Electromagnetic interference, which leads to inhibition of the pacemaker or pacing at a faster rate. Radiofrequency pulses are sensed at true cardiac signals. Usually it's not common, and usually the conditional devices reduce the electromagnetic interference, the EMI. You can do it with asynchronous pacing in ppm. Induction of arrhythmia, this is very rare in clinical circumstances. And what is key is to do continuous monitoring of your patients. One thing I would like to stress is that the time under the magnet is of crucial importance. It's absolutely critical. The average of our MRIs take 50 minutes. We do cine, edema, localizers with a sequence we called SSPP. But when you have a device, the time under the magnet is absolutely critical. And usually people with more experience have said that the MRIs should last 30 minutes or less. A professor I had in Boston took 2 hours with the patients under the magnet. And despite the fact that I learned a lot from him and I love him, one thing that I learned with time is that from the financial point of view, as well as from the medical point of view, the shorter, the better for the patient. In patients with devices, maximum 30 minutes. That should be enough unless there are complications or patients with congenital heart disease. And the less time we take, these dangerous situations will go away. There can also be changes in the reed switch. The magnetic field can activate the reed switch, which results in asynchronous pacing, or in therapy in patients with defibrillators. Variable incidence, usually higher, determined by distance of the lead and the magnet bore. Conditional devices use Hall sensor so that the reed switch becomes more predictable. And finally, to revert to default factory settings, the pacemakers, radiofrequency produce static and dynamic pulses and may induce alternate currents. Variable incidence more common in devices older than 2002. Continuous monitoring is required, and avoid scanning devices from before 2002. You have to be particularly careful with them because they can lead to complications. So these are the risks I already mentioned: mechanical movement, current induction, and tissue heating. At the lead interface, EMI, electromagnetic interference, change in read switch and revert to default settings in pacemakers. And the most important part of all is good communication. When we select patients, because this is the first step to avoid complications. Have a team-based approach. These are all the groups we work with. These are the cardiologists that together with us are the most important source of patients' reference, surgeons, and this group of patients to determine whether a patient is a candidate for surgical revascularization. But the best way to choose your patients is by talking to your colleagues. What other steps can you use? Well, having checklists, the type of device, the time, the pacing thresholds in terms of impedance and threshold, and which are the components, and know whether all the equipment is conditional or not. If one part is conditional and the other is not, that makes the whole system non-conditional. What I am going to show you comes from the paper of the HOS. These are checkups they recommend to be given to all the devices before and after the MRI. This is mandatory when you are scanning patients with devices. What can we do to have a safer environment, to avoid the 3.0? It's less compatible with devices, and preferably to do conditional devices. Minimize SAR, that's what we have to do. But I mentioned this because this is one of the mechanisms we use to reduce the risk of patients, to avoid epicardial leads and abandoned leads, avoid devices that have been implanted prior to 2002, and minimize the SAR measured in watts, to use asynchronous pacing in ppm-dependent patients. These are the changes we make in our patients. Constant monitoring, and try to have a cardiologist next to you and have everybody ready to start a resuscitation protocol as needed. There are many patients scanned with conditional and non-conditional devices, but it is better to be prepared for any occurrence and reduce the time under the scanner, because the time under the scanner is proportional to complications. If you talk to the people doing the scanners, you can see how long they take. If they are taking an hour and a half, 120 minutes, you must talk to them in order to shorten the time as much as possible. These are the conditional devices. They are increasing in numbers, and fortunately, their occurrence has greatly facilitated our life because it's easier for us to do these studies. And in non-conditional devices, it is very clear that there has to be documentation with the patient, with the electrophysiologist, about risk and benefits, because they have more electromagnetic tissue that will interfere and result in complications. PET is a great friend when we have inflammation, sarcoidosis, or a patient that is considering hibernation, because it is a safer method in this type of patients. If we are going to do an MRI in a patient, the clinical course has to be changed. It must not be academic suspicion. And always do a chest X-ray. And the electrophysiologist should also be close to us, and avoid doing epicardial or abandon, particularly the non-conditional. What is the evidence of safety in our patients? There are several cohorts with 1.5 Tesla from different groups. This is cMRI, Cleveland Clinic, Michigan group. And in general, when you look at the number of studies. There are 8 multicentric studies and 7 from single centers in conditional devices. There is 1 multicentric and 20 of single centers in non-conditional, and in total, there are 4,500 patients published and over 5,500 scans, because sometimes the patient undergoes 2 scans. So what has been published is that it is safe as long as we follow the guidelines. What about quality? Definitely Shiv Kumar, and particularly this guy, Pen Hu, a physicist of UCLA, greatly facilitated our lives. They established a new sequence, which is called the wideband, and now these sequences can be interpreted. This requires a talk in itself, so I won't go into the details, but you can rest assured that if this is done in expert hands with excellent equipment, the results will be satisfactory, not as the ones you see in the MRI I will show you tomorrow, but they can be interpreted. So these were the questions asked to the Italians. Only 6.1% of them answered, what is a conditional MRI? You know that these are devices that allow us to do the MRI under certain conditions. Nobody knew that in Italy. Almost half of them answered, if you decided to do an MRI and the patient needs to be checked, both the generator and the device should be checked. Otherwise, the system is not conditional. Less than 50% knew that 6 weeks was the ideal time to do the scan after the implant, and less than half of them knew that the device has to be checked before and after the MRI. Prosthetic valves, we mentioned them, it's safe. Coronary stents are safe. Loop recorders are safe as well. And these are the take-home messages. If you are about to start a program of MRI with devices, you must have 1.5 Tesla. 3.0 is too difficult, and you will have more artifacts. So if you haven't bought it, consider the 1.5. And the quality of the images is excellent. They are more compatible than Obama and Putin. This is the summary of risks. I mentioned them already. This is the way to mitigate them. 3.0, minimize ZAR, use asynchronous pacing in PPM-dependent patients, and always keep in mind a team approach. And that's basically all. This is the Center of Cardiovascular Images. My colleagues, my boss, Dr. Salazar, Dr. Jaimes, Dr. Forero, all our technicians. And I think that experience is also important. We did 6 MRIs that we have to interpret today. To do MRIs with devices, you have to first learn to do it in patients without devices. If you have any questions, this is my email. So you can write to me whenever you want, or if you want to ask questions now, please do so. Are there any questions? I would like to know which are the vendors of those of you who are already doing MRIs in patients with devices. What's your equipment? Which is your vendor, Siemens or Philips? Siemens. And you are doing devices in patients with 3 Tesla or 1.5? 1.5, perfect. You can clearly see the scar with 1.5. Where are you located? In Cali. Your name is Mauricio Mejia? Fernando Pavon, okay. How many patients have you scanned with devices? About 30. Yeah, we are working with pacemakers and defibrillators. We have 5. And how about the image quality? It's okay. It's just to do procedures. Oh, it's extracardiac. Okay. No, the specific question is how many of you are doing cardiac MRI in patients with devices? No, we also do cardiac diagnostic. With devices? Yes, patients with devices. Questions or any further comments? Any further comments about safety? An MRI in patients with cardioresynchronizers. We have spoken about endocardic leads, but if we have a resynchronizer, we have an epicardic lead, and there can be some differences in terms of safety. Yes, I think it was number 3 or 4 to generate currents and to have an asynchronic condition of the device. When this occurs, we prefer to turn off the device or the lead that goes to the left ventricle. The completely conditional devices for MRI and cardioresynchronizers is the newest trend. I think that in Brazil they are already implanting Yes, good afternoon. I come from Mexico. In Mexico, we implant pacemakers and we do MRI, but I have had patients that are not compatible. We have put them in the asynchronous mode with 1.5 Tesla and nothing has happened. Yeah, that's the way to do it in those which are in mode demand with cardiac rates below 60 or even below 50, who are hemodynamically stable. Well, thank you very much, and thank you for the invitation again.